Hey everybody, welcome back. My name is Quick and I'm here to teach you all about biochemistry. Biochem is one of those topics where boards is looking for pure regurgitation of facts with little applied logic. The best way to study any topic is through practice questions, and this is even more true for biochem. So let's jump right into questions. If you want to try questions on your own, I have put the link in the description. Feel free to click it, try that, and then whatever you get wrong, you can come back here and we could go over it together. For question 1, I want you to employ our method like we always do. For those new here, our method is to start by reading the last 1 or 2 sentences of the question stem, then the answers, and finally the full question once you know what the hell you're looking for. And this includes highlighting keywords, etc. So I will highlight the first one for you just this time so you can see what I'm talking about, and then from there on, it's all you. Alright, so let's begin reading where I bolded. A lateral ligamentous tear was discovered and surgical repair was performed. Arthroscopy reveals blue-black bone and hyaline cartilage. The deficient enzyme in this patient normally degrades which amino acid? A. Alanine, B. Tyrosine, C. Isoleucine, D. Taurine, E. Elastin. Alright, let's read it in full. So in this question we have a patient that presents with joint pain, black-blue cartilage, dark urine, and it's a young adult, which also kind of hints that it's a condition that is genetic. Which leads us to what condition? You should be saying Alkaptonuria. Hopefully you reviewed this topic. If not, it's okay. We're going to go through this concept. It's pretty high yield. You see it on a lot of different questions and question banks. So in this condition, right, Alkaptonuria, you get a buildup of homogentisic acid, which deposits in cartilage and joint spaces. Now, if what I'm saying to you is like Mandarin, I suggest that you go and do some content review, or you could just memorize what I'm about to say. You don't have to know every enzyme, but you should know high-yield facts, such as homogentisic acid is an intermediate in the metabolic conversion of tyrosine, which is our answer. So, just in summary, alkaptonuria is a deficiency of the enzyme that breaks down homogentisic acid, which is a toxic metabolite in the metabolic manipulation of tyrosine. And this buildup occurs within joints and hyaline cartilage. It gives blue-black tones and hues to bones and cartilage. And this results in joint pain, dark urine, and blue-black cartilage, as we've seen in this question. All right, let's try question 2. Question 2 is pretty short, so try it on your own for about half a minute, and then we'll reconvene and talk about the answers, okay? Okay, so we have a young boy with developmental delay with the finding to the right. You may already know, but this is a classic image of a cherry red macula. This is due to retinal opacification secondary to accumulation of a substance in ganglion cells. Whenever you see these findings, you should think of the lysosomal storage diseases. These findings correlate best with either Tay-Sachs or Niemann-Pick type A or B. So how do we differentiate between these two? Because this is a pretty high-yield concept that boards love to test. It's actually pretty simple. If you have hepatomegaly, it's Niemann-Pick. If not, it's Tay-Sachs. Can't make it any easier than that. So let's go through with which disease each answer correlates. A. Sphingomyelin buildup. Well, that's hallmark for Niemann-Pick. B. G6P, or glucose-6-phosphate buildup, is von Gehrig's disease. C. Cerebroside. So that could either be Crab or Gaucher's, whether it's gluco or galactocerebrosidase. D. Ceramide trihexoside. Well, that's Fabry, right? Fabry. And E. GM2 ganglioside. Well, that's what's building up in Tay-Sachs disease. So we already discussed we're between, right, A and E, because that is Niemann-Pick and Tay-Sachs disease respectively. And I told you that the differentiation is based on hepatomegaly. So the last sentence says percussion and palpation of the liver is unremarkable. In other words, there's no hepatomegaly. So in this case, it's going to be E, GM2 ganglioside, because this patient has Tay-Sachs. All right, on to question 3. Give this question a quick try. I tried to make it a bit challenging, so congratulations if you're able to get it, but I'll give you about, half a minute. If you need more time, feel free to pause me when I start talking again, okay? All right, now this question is tricky because it is not enough to know what condition this patient has, but you must know the pathogenesis of each of the answer choices. So this is actually pretty time consuming. So let's read through this quickly and go over each answer. A 34-year-old woman with a past medical history remarkable for hay fever is brought to the clinic for 2 days of coughing up blood. Complete metabolic panel shows elevated levels of creatinine and blood urea nitrogen. Her urine is dark and tests positive for heme on dipstick analysis. What other condition affects the same tissue? A. Epidermolysis bullosa. B. Menkes disease. C. Marfan syndrome. D. Alport syndrome. E. Ehlers-Danlos syndrome. Okay, so let's just go over what tissues each answer choice affects. So A, affects the skin, specifically keratinocytes. B, affects the formation of collagen in the hair, skin, etc. C, affects fibrillin, which kind of goes hand in hand with elastin, that affects vessels, right, elastic vessels. D, affects type 4 collagen, specifically in the basement membrane of the kidney, eye, and ear. E, affects type 3 or 5 collagen, depending if it's classic or non-classic Ehlers-Danlos syndrome, which could be found in the vessels and tendons. So what does this patient have? If you are able to identify it, that's half the battle right there. So we have something affecting the lungs, right? She's coughing up blood. We have something affecting the kidneys because of the elevated creatinine and blood urea nitrogen levels, and the urine is dark. You have hemoptysis and you have hematuria. So that goes most closely associated with good Pasture syndrome. And I even threw in another hint here, hay fever. If you know your HLAs very well, HLA-DR2 has hay fever, multiple sclerosis, and good Pasture syndrome. And also lupus, right? SLE2-3. So what you should be considering is if you knew the HLAs, you could kind of confirm it there. But just from presentation, it looks like good Pasture syndrome anyway. And what does good Pasture syndrome affect? It affects type 4 collagen in the basement membrane of the kidney and of the alveoli. So what other answer choice that we went over has that? You should be saying D right about now, right? Alport syndrome, because that affects type 4 collagen, specifically in the basement membrane of the kidney, eye, and ear. All right, so that's pretty good. That was a tough question. Good job on that one. Let's go over question 4 together. All right, let's read this one together. A newborn presents with lethargy and failure to thrive. Physical exam shows decreased breathing effort. A urinalysis is performed with the results below: specific gravity 1.02, pH 5.2, ketones are positive, amino acids is elevated for leucine and valine. A defect in which enzyme is most likely responsible for this newborn's condition? A, phenylalanine hydroxylase. B, alpha-ketoacid dehydrogenase. C, SGLT2. D, tetrahydrobiopterin synthase. E, cyclooxygenase 1. So let's just try to internalize and digest this question a little bit. So we have an abnormal urinalysis and failure to thrive in a newborn. This should be screaming congenital defect or some sort of enzymatic deficiency in your head right now. What is unique, however, is the presence of leucine and valine in the urine. Now, whenever they give you amino acids in the urine, you want to make note of which group they fall under. Right, so what group does leucine and valine fall under? So if you remember the mnemonic, VIL, right, VIL, you'll remember the branch chain amino acids. So that stands for valine, isoleucine, leucine, VIL. And usually all amino acids are reabsorbed in the proximal convoluted tubule, so you should not have amino acids at all in a significant concentration being present or excreted in the urine. So this is a know it or you don't kind of question. You want to take note of what you find in the urine. That's pretty unique. So in this question, right, it's the 2 amino acids. It probably is the third one as well, right? We spoke about isoleucine. But they gave you these two because they want you to think, all right, what group do they fall under? And how do you get from there to the answer choice? So in order for anything to show up in the urine, it either cannot be reabsorbed or it cannot be metabolized, and you have a tremendous buildup in the blood. And then that gets filtered eventually, and it all ends up in the kidney, and then you can't reabsorb quickly enough. So we're looking for an enzyme that metabolizes branch chain amino acids. So the presence of branch chain amino acids in the urine is actually hallmark for alpha-ketoacid dehydrogenase deficiency. And that's the specific enzyme that metabolizes the branch chain amino acids. So another name for this condition is maple syrup urine disease, because you can smell a sweet syrup-like odor in the patient's urine. So choice B, alpha-ketoacid dehydrogenase, is our answer. All right, let's move on to the next question. All right, so this is a short question too. Let's just read it in full. Acetyl-CoA is an allosteric activator of a mitochondrial enzyme involved in gluconeogenesis. In healthy individuals, the fasting state increases fat breakdown into acetyl-CoA and glycerol. Both acetyl-CoA and glycerol can be converted to glucose through upregulation of gluconeogenesis. Regarding the enzyme that acetyl-CoA activates, what is the product of the reaction it catalyzes? A, glucose 1-phosphate. B, glucose 6-phosphate. C, fructose 6-phosphate. D, galactose 1-phosphate. Or E, oxaloacetate. So no surprise here, this is just more regurgitation of fact. You should know, just from normal biochemistry, that acetyl-CoA is an activator of gluconeogenesis. If you didn't know that, it tells you in the question anyway. I just wanted to get the concept across. But specifically, which enzyme is acetyl-CoA required for as an activator? Now, if you're saying pyruvate carboxylase, which is the enzyme that adds a carbon onto pyruvate, then you're correct. So you need to know the substrate, the enzyme, and the product that is the specific step for acetyl-CoA activation, because acetyl-CoA only really activates 2 enzymes. It's only required as an activator for 2 enzymes, and one of them, which is the more high-yield one, is for gluconeogenesis, pyruvate carboxylase. So what's the product of pyruvate carboxylase? So you could go the biochem route, where you know that pyruvate is 3 carbons, and you're adding on carbon dioxide, right, because carboxylases add on 1 carbon. So you could already know that choices A through D are not correct through that way alone, because glucose, fructose, and galactose all have more than 4 carbons. And if pyruvate has 3 carbons and you're adding 1 carbon on because it's a carboxylase enzyme, well, then you're only going to have 4 carbons. So you could already get to oxaloacetate as the answer, which it is, just through the biochemistry route. Or you could just do it by memorizing it, which is, to me, a little bit easier. Right? You go from pyruvate to oxaloacetate, which could leave the mitochondrial membrane, and it could go out into the cytoplasm for gluconeogenesis. So in summary, acetyl-CoA activates pyruvate carboxylase, which adds a carbon to pyruvate, converting it to oxaloacetate, which promotes the first step of gluconeogenesis. I know it's not the most fun thing to do biochemistry, but you do need to learn these high-yield concepts. Okay, I personally think this question is a great question. It's a great concept to know, and it's pretty high yield because maybe you will see this in the clinic, and if you point it out, you'll look like a genius to everyone. So let's start reading. A patient is admitted for severe epigastric pain that radiates to the back. The physician appropriately treats him with fluids and holding feeding. The patient has never experienced this pain before. He has a family history significant for dyslipidemia, so you decide to run a lipid panel. The serum triglyceride level is 1,130. The drug of choice for this patient works through which mechanism? A. It inhibits HMG-CoA reductase. B. It inhibits colipase. C. It sequesters bile acids. D. It inhibits cholesterol acyltransferase. E. It increases activity of lipoprotein lipase. So let's just once again dissect the question. What does this patient have? You should be saying pancreatitis. Right? If you have a very high triglyceride level, usually over 1,000, you're at a high risk for pancreatitis secondary to hypertriglyceridemia. And there's always one drug specifically that works best to decrease the triglyceride levels in the serum. Right? Because pancreatitis caused by over 1,000 milligrams per deciliter of triglyceride in the serum, you want to decrease that triglyceride in the serum, at least the concentration of it, in order to prevent or resolve this pancreatitis. Otherwise, it will be ongoing and it could cause a whole bunch of complications. So which drug class is meant to specifically lower triglyceride levels, which will, in turn, downstream, stop this patient's pancreatitis from progressing? All right, hopefully you're saying fibrates. Now, how do fibrates work? So fibrates are a little bit tricky. You'll see that it has multiple mechanisms. The 2 that you should know is that fibrates inhibit 7-alpha hydroxylase, right? That's for formation of cholesterol. And it also activates lipoprotein lipase, which breaks down triacylglycerides, right? Or tags, right? Some people say TAGS, tags. So we see that that's actually an answer choice, right? Answer choice E, which is the correct answer, increases activity of lipoprotein lipase. So like we said, in order to stop this patient's pancreatitis, which is secondary to hypertriglyceridemia, you have to lower the triglyceride levels. The drug that best does that, at least the class of drugs that best do that, are the fibrates. And the fibrates work by 2 mechanisms. They inhibit 7-alpha hydroxylase, which is for conversion to cholesterol, and they activate lipoprotein lipase, which breaks down TAGs or triacylglycerides. All right, let's look at the next question. This question is short, but it is super, super high yield. I think it's shown up on everyone's board exam at some point, whether it's step 1, 2, so on. A diabetic patient is on metformin, atorvastatin, fenofibrate, and lisinopril. He has recently begun to experience pain in his calf, which has worsened when he walks up and down stairs. What is the mechanism behind the pain that the patient is experiencing? A. It's a combined side effect profile of the atorvastatin and metformin. B. It's caused by a decrease in dialysate synthesis. C. It's caused by a decrease in ubiquinone synthesis. D. Autoimmune antibody formation. E. It's caused by fatty deposition on tendons. All right, so the patient's experiencing calf pain, and they specifically say the word calf to make you think myopathy, right? So the patient's having a myopathy. So this is super high yield, as mentioned before, and you should just commit this to memory because it will show up both in clinic and on the exams. So as many of you may know or may have studied already, fibrates and statins, that combination specifically, is very likely to cause myopathies. Now, why is that? It's not enough to just know that. You have to also know a little bit about the mechanism of action behind it. So the mechanism of action behind myopathies, secondary to fibrates and statin administration, is that you decrease the conversion to mevalonate, which is in the pathway to make cholesterol. But that same pathway, there's little branches in that pathway to form ubiquinone, which is in the electron transport chain. Right now it's starting to click a little bit. Okay, if you mess with the electron transport chain, you mess with the mitochondria. Where are most of the mitochondria? It's pretty heavily in muscle, right? You're depleting ATP. You're not able to actually make the ATP because the electron transport chain is disrupted, and that's going to cause myocyte spasms or tensing. You can think of it kind of like rigor mortis, where when you die, you no longer make ATP, and your muscles stiffen because you don't have any new ATP to kick the ADP off of the myosin and actin. So it's caused by a decrease in ubiquinone synthesis. So choice C is the correct choice. And we spoke about this a little bit before. On their own, fibrates could also cause myopathies. Statins could also cause myopathies. Basically, anything that affects the early portion of the cholesterol synthesis pathway will mess with ubiquinone synthesis, and that's going to give you myopathy. So be very wary when you see a patient in the question stem who's taking fibrates or statin or both. And boards typically like to test this in terms of, you have two similar side effects or two of the same side effects from two different drugs. They're going to give you both drugs and say, what's most likely to happen or how is it going to happen. So we're on question 8. We have 2 more to go after this. You're doing a great job. Let's keep up the good work. Let's start reading from where it says, she wants to know. She wants to know what the risk is that she will pass on her condition to her child if she were to conceive. Which technique can be used to determine if her husband is a carrier of the mutant gene? A. ELISA assay. B. Fluorescent in situ hybridization, also known as FISH. C. Western blot. D. Polymerase chain reaction and sequencing, also known as PCR. Or E. Southern blot. So before we read the beginning of the question, we know they are looking for a test that detects the presence of a mutated gene. So let's read the beginning and try to identify the condition, and then we'll talk about which answer choices are correct. A white 27-year-old woman who has been unsuccessful in getting pregnant with her husband has a history of recurrent respiratory infections and fat-soluble vitamin deficiency. She is currently on pancreatic enzyme replacement therapy. She wants to know what the risk is that she will pass on her condition to her child if she were to conceive. So whenever you see respiratory infection, especially with fat-soluble vitamin deficiency, and definitely when you see decreased pancreatic secretions or you need some sort of pancreatic enzyme replacement therapy, you should immediately be thinking cystic fibrosis. So you actually don't need to know any of that I just said within the past 10 seconds if you just read the last portion. We are looking for a test or a technique that will determine if her husband is a carrier of a mutant gene. So we need to know every single one of these tests, what they test for. So let's go through each one. A. ELISA test. Well, that tests proteins, enzymes, and substrates. Are we looking for proteins, enzymes, or substrates? No, we're looking for gene, right? A gene is DNA. How about FISH? Well, FISH is for chromosomal changes, and it highlights a specific DNA sequence on chromosomes. It does not tell you if the codon or the portion of the gene has actually changed. It just usually shows you if there's a trisomy or if one's missing or deleted. How about the blots, right? C or E? Western and Southern, what do they measure? There's a mnemonic, and I'll pull up the page right now. The mnemonic is snowdrop. So if you line up the letters, S-N-O-W, and you line them up to D-R-O-P, you get S goes with D, N goes with R, and W goes with P, right? O's cancel out. So Southern tests for DNA, Northern tests for RNA, and W, or Western, tests for protein. Okay, and we said we're looking for a gene, right? And we're looking for specifically DNA, especially with cystic fibrosis, right? If you really want to go into detail, there's a little bit more in the respiratory lecture that I went over. But it's a change or a deletion in the phenylalanine in the 508 position of the CFTR protein. Now, out of both Western and Southern blot, which one tests for DNA? Southern blot. Okay, how about polymerase chain reaction and sequencing? So PCR is actually the optimal choice for detection of DNA gene mutation. So technically, if you really want to, be kind of a wise guy over here, a wise girl, you would say, quick, Southern blot could also be used. Yeah, but here's the thing. You technically can use Southern blot, but it is more time consuming. You need more DNA sample and it's not as reliable or as fast. So technically the question should say which technique should be used, not could be used. So I apologize for that, but in either case, you should know that PCR is always the favorite to detect genetic mutations, specifically in the DNA. Right? You have specific probes that will tell you which specific type of change occurred, and it'll be able to pinpoint you exactly as to what codon even is messed up. Okay, so once again, technically, yes, Southern blot can actually detect DNA changes, right, on the genetic level, but it is inferior to PCR testing. You want to choose PCR for these types of questions, especially, you'll see probably cystic fibrosis and a whole bunch of other genetic mutations in the DNA. If they ever ask for DNA, you want to look for PCR first. If it's not there, then you could choose Southern blot. All right, I know that was a tough one. Hopefully, you got that mnemonic down, and if not, you can always refer back to the video whenever you want. I'm always here, but until then, let's move on to the next question. Okay, so since this is the second to last question, I want to give this one a shot, and we'll go over it together. I'll give you about 10-15 seconds. Feel free to pause me. All right, so what keywords did you find? What helps you with this question? Hopefully, you made note of the femoral pain, the pancytopenia, the hepatosplenomegaly, and the lipid-containing macrophages. So which condition best suits this? Once again, this is kind of just regurgitation of fact. You should be able to identify these signs and be able to correlate it with the condition. Hopefully, you're telling me Gaucher's disease or Gaucher's disease, right? Gaucher''S. Gaucher's disease or Gaucher's disease. So Gaucher's is defined by avascular necrosis, usually of the femoral head, pancytopenia, lipid-laden macrophages, and hepatosplenomegaly. Now, something that is high yield is that all of the lysosomal storage diseases are autosomal recessive except Fabry and Hunter's disease. Those are both X-linked recessive. In general, this just kind of goes for all of biochemistry. If it's a disease that is categorized by missing or being deficient in an enzyme, usually it is going to be autosomal recessive. Okay, so let me explain the logic to you behind that. So usually if you're only missing one of the enzyme, you have two copies of the enzymes, right? If you get rid of one of those genetic copies, you've cut the concentration in half. Now, most of the time, that one remaining functional enzyme is more than enough to compensate for any loss in terms of the concentration of the enzyme present, right? Usually you're not working at full saturation, so you usually actually need both to be knocked out in order to actually see the phenotype of the disease. Now, this doesn't apply for every single enzyme deficiency, but this is the rule, right? This is the overall rule, and you will see exceptions as with any other rule. But when in doubt, if you're able to identify that there's an enzyme missing, then I want you to automatically assume autosomal recessive unless proven otherwise. And by and large, most things actually are autosomal recessive. I always found it easier when I was studying for boards to memorize the autosomal dominants, the X-links, and the mitochondrial, and then everything else just defaulted to autosomal recessive. And that helped me out a lot, because you don't want to have to memorize every single thing in the book if you could get by with memorizing half of it and being correct on the other half just by assumption. Okay, so we already discussed this answer. Gaucher's disease is what? Is it autosomal recessive? Is it autosomal dominant? Is it X-linked recessive, X-linked dominant, mitochondrial? Yeah, like we said, it's autosomal recessive. All the lysosomal storage diseases are all autosomal recessive except Fabry and Hunter syndrome. And the Hunter one is actually pretty easy to remember because X marks the spot. That's how I always think of it. Hunter, you have X marking the spot for a Hunter. And that's how you know it's X-linked recessive. Fabry, you're kind of on your own. Just memorize it. I wish I had a better mnemonic for you. All right, let's move on to our next and final question. So before we delve into this question, I just want to say that I made this question particularly because I always thought this was a weak spot that was never taught well to me, and it's pretty easy to just memorize. But nobody really brings it up, except maybe in a few question banks, but I haven't really seen it much else from there, and I think it's very high yield. Boards love to target the concept of inflammation. If you really want to do like a deep content dive, I highly, highly, highly recommend doing Pathoma chapters 1 through 3, which cover inflammation, apoptosis, necrosis, inflammasomes, all that stuff, a little bit of neoplasms, dysplasias, metaplasias, all that stuff. But I really, really want to focus on the inflammatory response because that's exactly what boards loves to test on. And that's what a lot of people actually don't really know all that much about for some reason. I had to look it up on my own before the exam, and I'm really grateful I did because I saw a ton of acute inflammatory and chronic inflammatory response questions on my test. All right, with that being said, let's delve on into this question. Acute phase reactant proteins have been of large interest in the medical community due to their apparent ability to indicate an acute inflammatory response. Most of these proteins are produced by the liver in times of bodily stress, infection, or trauma. Which of the following proteins is downregulated in acute inflammation? A. Alpha-1 antitrypsin, B. ceruloplasmin, C. C-reactive peptide, D. Albumin, or E. haptoglobin. Okay, so you need to know the acute phase reactant proteins, and you have to know which ones increase, which ones decrease. You have to know, for example, in like bacterial infections, procalcitonin will increase, but in viral infections, it will decrease. In this specific case, they're just wondering, in the generic acute inflammatory response, what do you think you have less of? Now, you may or may not know it, but you will actually have a decreased level of serum albumin. And here's the reason behind this. There's actually a couple pathways or a couple mechanisms behind this. So in acute inflammation, it's partially defined with an increase in vessel permeability, which allows serum albumin to escape. So that's one way it decreases. There's also evidence to suggest that the half-life of albumin shortens during these events, right? In an acute inflammatory response, albumin half-life could shorten, which would also decrease the serum albumin concentration. And finally, its synthesis is actually decreased in the liver, right? The liver produces albumin, but in acute inflammation, the liver actually decreases its synthesis, or it synthesizes albumin at a slower rate. So all of these combine lead to the decrease in albumin that we see in an acute inflammatory response. Whew, that was pretty rough, but you guys stuck it out, and I'm proud of you for it. You're going to be that much better. Well, that was it for this video. Be sure to check out our High Yield Question Bank series in order to prepare for your boards. If you get anything wrong and need an explanation, jump on over to the corresponding explanations video. If you want to show support, or if you find our material helpful, please like, subscribe, and share these videos. It really goes a long way, and your support means very much to us. Thank you, and see you in the next video. Keep up the good work.